See, voice is audible. Hello?
Yes, sir. Yes, sir. Your voice is audible, sir. Yes, sir. Yes, sir.
Right. Share my presentation and let me see that. Yeah.
MS Reddy garu, good evening.
Hello. Good evening. Good
Good evening.
evening. How are you?
Sir.
Sir, are you able to share your slides, sir?
I'll just share my presentation.
Okay.
Yes,
Yeah,
Sir.
should be.
Yes,
Are you
sir.
able to see?
Yes, sir.
Oh,
Yes,
yeah.
sir.
That's it. Okay. So I'll stop sharing now.
Yes,
That's
sir.
it. No, we have a lot of
Sir.
time. I
Yes,
think
sir.
more than
10
10
minutes.
minutes.
Yes.
Yes. So good to come back again to World Bipolar Day. Actually, the program last week I thought I'll do in Hyderabad. That got postponed because there's a PGCME.
Yes, sir.
So it just got postponed. Next, like that. So how is everything? All good?
All good, sir.
Oh, గుంటూరు ఎండలు ఎట్లున్నాయండి?
బాగా ఎక్కువగా ఉన్నాయి సార్ ఇక్కడ.
అవును, హైదరాబాద్ ఆల్సో ఇట్స్ లైక్
9:30కే 12:30 2:30 11 3:30 ఎండలు.
అవును, it's become like that. So the slides అయితే the deck was sort of distributed. No, it's put on the
మీరు ఇచ్చిన స్లైడ్స్
everybody
అందరికీ
has.
పెట్టేసాను. అన్ని
Yeah.
గ్రూప్స్ పెట్టేసాను.
Except 2-3 slides is the act is అంతే. I think mostly let us see that.
Yes, sir.
I just even want to know like what is their reaction when you present the slides. Then it's not a specific topic, it's a few point by point. Between us, people have not joined it, no?
Yes, sir.
Do you agree with some of the things what I say?
Regarding what, sir?
Bipolar.
What did you say, sir?
No, whatever I mentioned there,
Oh, fine.
slide long, it's always something like that. Okay. So Murthy is also there. Good evening, President Garu. GS Murthy is there. Yeah.
ఆయన మ్యూట్ లో ఉన్నారు సార్, వస్తారు.
Mm.
Everybody joined.
Yeah. Okay. Yeah. That's good. So we are starting at 8.
Sharply at 8, sir.
Right.
Sharply at 8.
Whenever you say go, right. Yes, ma'am.
శరత్ హిమకర్ గారికి ఫోన్ చేయలేము. శరత్
నేను చేస్తున్నాను.
లైన్ లోనే ఉన్నాను సార్, సార్తోనే ఉన్నాను, లైన్ లోనే ఉన్నాం.
ఓకే ఓకే కరెక్ట్.
ఓకే. అందరూ వచ్చారా? గుడ్ ఈవినింగ్ టు ఎవ్రీవన్ అండి.
Hello, good evening, Andy. President Garu, good evening.
గుడ్ ఈవినింగ్ సార్. ఎంఎస్ రెడ్డి
Good
గారు గుడ్
evening.
ఈవినింగ్.
How are you? Good evening, Andy. That's Suresh.
గుడ్ ఈవినింగ్ సార్. గుడ్ ఈవినింగ్. వెల్కమ్ యూ ఫర్ టుడేస్
Thank you.
సైంటిఫిక్ ప్రోగ్రామ్.
Thank you.
Sir, good evening, sir. Dr. Umajyot, sir.
Good evening. Yes, ma. Good evening. I know. Good evening. How are you?
Fine, sir. Thank you, sir.
Good.
శరత్ ఏంటి హిమకర్ గారు లేటు?
ఆయన టెక్నికల్ గ్లిచెస్ ఏమైనా ఉన్నాయో చూడాలి.
గుడ్ ఈవినింగ్ డాక్టర్ ప్రసాదరావు గారు.
Hello,
హలో
President Rao.
హలో గుడ్ ఈవినింగ్ డాక్టర్ ప్రసాదరావు గారు.
Where is he?
నమస్కారం.
నమస్కారం సార్.
Hello, President Rao. Good evening. President Rao, your voice is breaking.
లోకేష్ సార్, సార్ ఒకసారి హిమకర్ సార్కి ఫోన్ చేయరా, ఆయనకి ఏదో ప్రాబ్లం ఉంది.
ఏమైంది?
ఆయనకి ఏదో ఓపెన్ అవ్వట్లేదండి సార్. ఆయన డెస్క్టాప్ లో ఓపెన్ అవ్వట్లేట, సెల్ ఫోన్ లో ఓపెన్ అవ్వట్లేట. లింక్ మీద కొడుకుంటా.
లింక్ మళ్ళీ పెట్టేసి
లింక్ మళ్ళీ పెట్టాను.
అది ఎంత కోడ్ అని చెప్పండి ఒకసారి.
ఏదేది?
పాస్కోడ్
అది ఆయనకి పంపించాను సార్.
పంపించారా?
ఆయన జూమ్ అదే కష్టంగా ఉంది, ఓపెన్ అవ్వట్లేదు. నెట్ ప్రాబ్లం ఏదో ఉన్నట్టుంది. ఆయన ఒక నిమిషం మీరు ఫోన్ చేయండి.
ఒక్క నిమిషం.
Sir, we'll start once Himakar sir joins.
Just
Okay.
a few minutes, and he has some issues. Okay, I'm getting it.
Correct.
Thank you.
Meanwhile, maybe before he joins, let me say a few things, share a few things. Formally, we'll start the topic once the chairperson joins. Very informally, I think I'm really very happy. There are about 50 people have joined. Thank you so much. Thank you so much. It's like my day is made. Even before starting the topic, it's like your love and affection, and then so much of the thing. Thanks each one of you. Thank you so much.
Thank you, sir. Thank you.
This time, I thought, like even the topic and this, no, this is something which I keep talking about. Maybe some of you get tired of listening to me, but I am not getting tired. I won't get tired also. This time I thought I'll share my presentation more or less. I think 90% of the slides I've shared it. So I think all of you must have gone through that also. Some of them don't know, some of you like, and some of them I'm sure some of you don't like them. It's okay, it's for the discussion. Broadly, let me see whether I can try to finish it in about half
Himakar
an
sir
hour,
joined,
40
sir.
minutes.
Ah.
Yeah, good.
Himakar
good.
sir joined.
Joined.
Yes. Yeah, Dr. Himakar joined.
ఎక్కడ
Joiner.
గుడ్ ఈవినింగ్
జాయిన్ అయ్యారు సార్.
హిమకర్ గారు.
సార్ వినిపిస్తుంది సార్ హిమకర్ సార్.
వినిపిస్తున్నారు సార్. మ్యూట్ చేయండి, సౌండ్ అన్మ్యూట్.
అన్మ్యూట్ సార్, అన్మ్యూట్. హిమకర్ సార్ అన్మ్యూట్.
చేశాను.
రైట్.
Hello, good evening.
చాలా గుడ్ ఈవినింగ్ సార్. గుడ్ ఈవినింగ్.
Good evening.
ఇది ఇందులో ఓపెన్ అయింది, సెల్ ఫోన్ లో.
అది
ఓపెన్ అవుతుంది అనుకున్నాను.
ఆ పొజిషన్ అలా ఉంచండి సార్, చాలా
Good, yeah, right.
ఓకే.
We shall start, sir.
ఓకే.
Good
Right,
evening.
we'll start then. We'll start, huh?
Yes.
Yes, sir.
See, all of us are colleagues. We are in the psychiatry practice for last so many years.
Sir, Himakar sir.
Himakar sir, 1 minute.
Sir,
If you take,
I'll just give a brief welcome, sir.
yes.
It will come, sir.
Yeah.
Sorry for the disturbance. Good evening, everyone. I welcome all the consultants, members, and students for this insightful webinar. As you all know, our IPS AP state branch remains committed to raising awareness and promoting discussions on various psychiatric disorders through such initiatives. And on the occasion of World Bipolar Day 2025, which is celebrated on 30th of March, so we are delighted to welcome you all to this webinar by our renowned psychiatrist, Dr. M.S. Reddy sir, who is much interested in bipolar disorder.
Thank you.
And I would also like to take this opportunity to appreciate the dedicated efforts of our state branch office and our esteemed members for their active role in organizing these meaningful activities. So these contributions are invaluable in spreading awareness and fostering a better understanding of mental health. With this brief introduction, now I request our President, Dr. G.V.S. Murthy sir, to give his message.
Good evening. Good evening to everyone, the esteemed guests, and including our speaker today, Dr. M.S. Reddy garu, and Chairperson, Dr. P. Himakar garu, and other office bearers, members, and students, postgraduates. I extend a warm welcome to you all for the CME program, which coincides with World Bipolar Day, as Dr. Lokesh already mentioned. And we are honored to have Dr. M.S. Reddy, an expert in bipolar disorder from Asha Hospital, Hyderabad, to share his experiences and insights with us today. And I extend my deepest gratitude to Dr. M.S. Reddy for graciously accepting our invitation to be the speaker for this CME. Thank you, Dr. M.S. Reddy garu.
Thank you, sir.
I am also delighted to inform you that Dr. M.S. Reddy has also accepted our invitation to deliver the prestigious IPS AP branch oration, that is Manasa Hospital Rajahmundry oration at AP.
Thank you.
upcoming AP Psychon. Thank you, sir. Thank you, Dr. Reddy.
Thank you.
I also want to express my sincere appreciation to Dr. P. Himakar Garu for readily accepting our request to chair this event. And thank you, Dr. Himakar Garu. And I urge all the postgraduate to seize this opportunity to gain a deeper knowledge, deeper understanding into the bipolar disorder. And I'm also thrilled to announce that AP Psychon, our annual conference, will be held in Nellore from July on July 12th and 13th this year, under the chairmanship of Dr. Uday Kumar and organizing secretary Dr. Srinivas Teja. I kindly request all the members and postgraduates to register for this event. And incidentally, today Dr. Teja made his first announcement, released his first announcement regarding this event. I congratulate the organizing team for this. Thank you all, and over to CME committee. Thank you.
Now I request Dr. G. Suresh Kumar sir, Chairman CME committee, to give his brief message and introduce the chairperson for today's webinar. Sir, over to you, sir.
Good evening, respected office bearers, president, and the team, and colleagues, dear friends and students. On this occasion, the World Bipolar Day. We are conducting today's the scientific program. As such, we are conducting many mental health days being observed through various awareness programs and webinars in hybrid forms and the physical forms. Recently, we had conducted the midterm CME at Anantapur, which is a very successful and all the members are well appreciated by these programs. And today's we have fortunate to have with us Dr. M.S. Reddy Garu. Is an authoritative figure on this area of bipolar disorders. He is the director Asha Bipolar Clinic. He is very knowledgeable and he is very senior person. He needs no introduction to our both the states of Andhra Pradesh and Telangana. Not to he is confined to both the states, the entire India. He is a very popular figure in his expertise in this bipolar area. And another today's chairperson of today's session, Dr. Himakar sir, is my teacher, and he is a senior psychiatrist from Visakhapatnam. He is graduated from the Andhra Medical College, and later he pursued his post-graduation DPM and MD psychiatry from the CIP Ranchi in the prestigious institutes, and later he joined in Andhra Medical College as assistant professor in the year 1994 to 2000. Later he was promoted as an associate professor from 2000 to 2006, and later he worked as a professor from 2006 onwards, a brief period at Rangaraya Medical College, later again into the Andhra Medical College till 2022. He was worked as a professor HOD of the Andhra Medical College and superintendent government hospital for mental care. And he retired as a superintendent and additional director of medical education, Government General Hospital, Vijayanagaram. He is the past president of IPS AP State Branch. Dr. Himakar sir, as we are well aware, he is very academician, is confined to he talks less but very pertinent to the topic only. I over to the Himakar sir for to introduce the topic as well as the today's speaker. Over to Himakar sir, please sir.
Okay, good evening everybody. Bipolar disorder day, on the day of this thing, we are having this program. It is very heartening. And Dr. M.S. Reddy does not require any introduction to anybody all over India. He's a very senior person, and actually his biodata has not come to me. Anyway,
Don't bother. Please don't bother.
Okay. we know you, sir. We know you very well. Every one of us will know you. And this thing that about coming to the today's bipolar the topic. Actually, we are in all of us. We are in the practice in practice of psychiatry for last 40 years. In these 40 years, we are seeing patients, and the presentation, all those things have varied, changed over a period of time. For example, when we were students, the related grandiose related kind of mania used to be very more common. And more this thing, and now over a period of time, we are not having seeing that kind of typical presentation of grandiose elated kind of mania. More often now we see more paranoid irritable type, more associated with the drug like alcoholic addiction with binge drinking. These kind of presentations are varied. Like as it happened, as you see in conversion disorder, and as things have changed in this bipolar illness, also things have changed. And our understanding also, like we have seen in the last 40 years, there are some patients in their lifetime, they had only 2-3 episodes, and rest of the life they continued very well, and they completed all their life responsibilities and served and retired nicely, and having comfortable kind of this thing. Where and the other thing is that, but there are some people who frequently relapse and having a very bad kind of prognosis, and symptomatic presentation is very difficult, and it is sometimes it is taxing on the psychiatrist also. By the you see, by the you see his prescription, you see one minimum drugs, 1 or 2 drugs, they are doing quite well. If more prescription, more drugs are added, that means he's not responding well. He's creating a problem on and off regularly. That kind of thing is where we are seeing. And again, in our understanding also, like in the beginning, we used to, our anti-cycling agents, all those things, mostly they used to prevent manic kind of episodes and reduce those things. In a depression, there's no specific effect of avoiding, like say, prophylactic action on depression. Like over a period of time, it has changed, and some new drugs have come, and lamotrigine, like that, which is more specific for preventing depression. That kind of thing has come. We have added, we are using, but the difficult cases are difficult cases. We do any kind of thing, it's not going to respond. And routine, the other cases, those people who respond well, they really respond well. And nobody will make out that he has an illness at some point of time. This kind of experience we have. So like in my practice, I meticulously keep all the records. I can review when I see all the last 40 years records. There are definitely around, say, 50-60% of the cases who have limited episodes in their life, and they continued this thing. But rest 30-40%, really the problem, this thing has come. And again, I have observed one thing, that in young people who are presenting with bipolar illness, in them the prognosis is not very good. Actually, it's not it's difficult to manage also. And again, this kind of diagnostic stability also. Sometimes the first episode, as you see mania, later on they develop schizophrenic features like that. There are so many things have happened in a particular patient. That kind of evolution is there. So, and what I mean to say is that even in our approach also, the diagnosis is also not very certain that this particular the patient is having this kind of prognosis. That kind of prediction we are unable to make now. So what I'm trying to say is that there are a lot of variation in presentation, lot of the treatment response also it varies. And that's why we have to update ourselves. We have to learn, and we have to. I listened all the most of the lectures given by MS Reddy Garu, and he has very good concept. He teaches very well about this thing, and now I request him to enlighten us on this this thing. Thank you, sir. Please
Thank you.
start your.
Thank you. Thank you so much for all your kind words. Thank you so much. AP chapters love. I feel humbled and honored. Thank you so much. So nice of you. So nice of you to get me back again here on this day. I think our chairperson today beautifully summarized. I think half my topic is done by him beautifully. Number one, random and chaotic way of in the course of the bipolar disorder. He said that some people have 2 episodes, some people have 10 episodes. He said beautifully that some people do excellent and they do all the functions in their lives and then they do very good. And he said some people do very good with 2 medicines and some people's polypharmacy is destroying all of us like that. And the picture variation, I think that's the essence of bipolar disorder. I think he has captured very nicely in those few sentences. Thank you very much, sir. I think it's really good. And you gave a good start to saying that few people do very good, at least in a section of patients, the prognosis is good, which I thought I'm going to talk about. And once again, I say that I feel really, initially, just before you came, I was very informally talking that I say that my day is made. When I shared my presentation, I was wondering what if these people of around 80 people present there, as I told that I feel extremely happy to know, like, all of you delegates there. And then thank you very much for being there. Now I share my presentation. Today's presentation, what I thought is that that's why I shared it beforehand so that all of you will have some idea about. Are you able to see my presentation? Yes, no?
Okay.
Yeah. So that you will have some idea about what exactly. There's nothing new about it. More or less those few slides, and maybe I have added 2-3 extra. As I was telling that, let me see if I can finish it in about 30-40 minutes. After that, now, like sometimes it's not so possible that like if it can be interactive, whether it is in the like the chat box or if the chairperson and then office bearers permit, make it, they can allow some people to come on live also. We can have some kind of an interaction. Okay? That's what the purpose of it. And today's there's nothing like a topic. 2-3 slides is one particular area I'm trying to talk about. There's no sequence. Sometimes you may you may find that I'm jumping from one topic to another. To start with, I think this is exactly what Dr. Himakar was talking about. This is very clearly that's what he is talking about. Like, this is one of my favorite slides. In a patient with a diagnosis of bipolar disorder, whether it is a manic episode or depression, and then here I would like to say that patient of any age group and gender, whatever may be the severity, whatever may be the duration, frequency, with or without psychosis, can I, as a treating psychiatrist, think of achieving complete symptomatic recovery? Sir, I once again mention symptomatic recovery. Some of you, I think there's somebody, if you can mute yourself, I'll be thankful. From the current episode, here the one thing is that caregiver is requested to take the care of preventing the suicidal attempt and overindulgence in manic episode. This is one slide which I keep putting quite a lot of my presentations. And my answer to this is without an unwavering yes. I say yes. There's no doubt about it. And then now, like, people may say that now, like, how can you say that? And then with what confidence you say that? Yes, this is my clinical practice. As Dr. Himakar was talking about in 40 years, I don't know, 35, 40 years of practice. Majority of the patients, let's not talk about 100%, majority, this is the beauty of bipolar disorder. This is the beauty of mood disorder. We can get them into symptomatic recovery without any doubt about it. Recovery is about changing lives, not just biochemistry. And then, where did you get this confidence? So Dr. MS Reddy, how do you talk about this kind of thing? My thing is that I think out of the people here, majority of your clinical psychiatrists, even though you're in the institutes, most of you practice psychiatry. I think almost all of us are clinical psychiatrists. We are all clinical psychiatrists. We practice clinical medicine, not just in like the research and the research oriented. 90% of us are clinical psychiatrists. When I say I'm a clinical psychiatrist, I am also a translational psychiatrist. Whatever is in the research, when Eli Lilly brought out Prozac or like fluoxetine from the research, I brought to the clinic, and all of you treated your patients and then showed it that this is an effective antidepressant. So every clinical psychiatrist, I call them as a translational psychiatrist from research to the clinic. And in the process, each and every one of you are also an advocacy psychiatrist. You practice clinical psychiatry. And in the process, you say that whatever is done in the research, whatever the drug which comes, it is translated into the clinical practice and it's effective. And in the process, you say that we have good drugs. I think Telugu, I think most of you, Manovyadiki Mandaledu. I think that concept we are going against, we are advocating saying that there are medicines, message of effectiveness we now like in a broadcast and it take the message to the crowd. That is why we are clinical translation advocacy psychiatrists. And then this is a statement I think all of you know, we talk about RCTs, but it's only less than 20% of patients satisfy the criteria. There's now like in a paper in this, now like a recent article in Bipolar Disorders 2022, where he talks about case reports are valuable. This is a statement from that book. Having practiced for more than 40 years, which I think suits more of even Himakaran than myself, case reports can provide rich descriptions of clinical effectiveness in a real-world setting, exactly as what Chairperson told. I also maintain the records of the patients for the last 15-20 years. That is where my confidence in my teaching comes from. This is one which I want all of you to spare 2 minutes in this. This is a very, very important slide for me. This is a very important slide. Actually, like when I say that on this eve of World Bipolar Day, let us all take a pledge. Let us all never forget that bipolar disorder is a good prognosis disorder. Natural course of bipolar disorder is a good prognosis mood disorder. If you look at this, let me take a minute on this. This is the onset of mania. The mania progresses. Suppose you don't treat, you don't touch it. It will go like this up to a point. This is the time frame. The concept is Kreplinian concept, episodic disorder concept. Majority of the patients, let's not talk about 100%. Majority of the patients, patient with mania has to recover. If you don't treat, he will recover. Then what is that? Why do you treat? No. The morbidity, mortality part of it, the kind of damage what he does, this is something we need to restrict. That is why whenever you give a drug, whether it is risperidone or olanzapine, you're bringing down this recovery process, hastening the process and bringing to the time frame. So otherwise you would have recovered here. Now we are bringing it forward. This is the beauty. This is what we all clinical psychiatrists do. An episode of mania, once again I reiterate, leave it alone. It will recover at some point of time, but we cannot afford to now cannot to intervene, not to do any intervention because of the risks associated with that. So intervention comes and this recovery process is facilitated, hastened, right? Now, some of the postgraduate dates in the younger generation, what I say that, suppose you are conducting a study, acute mania, you're testing risperidone versus placebo or some other drug versus placebo. If your time frame is 3 weeks, this period, clearly you see risperidone is better than placebo. If your time frame is, my primary outcome time frame is 2 months, that is at this period, risperidone, placebo, Reiki's, and then all the healing process become the same. That is where a lot of times there is a chance that we mistake that so many drugs are so effective. I think this is one point you have to understand. Same thing happens with the recurrence also. There's a period of gap before the next episode comes. During that period, whether it is lithium, valproate, lamotrigine, whatever the drug you give, they all seem to be effective. But the proof of the pudding is to what extent we can prevent or delay it. That's going to be the most important thing. That is why antagonizing the natural course, facilitating the natural course, which I think all of us have to remember. This is again the same thing with the depression I talked about. There it's mania, this depression. Now, just that, natural course and then how we hasten the process. When I talk about symptomatic recovery, a lot of times the questions come. MS Reddy, you're talking about, when you talk about symptomatic recovery, you're forgetting subsyndromal symptoms. That is why I brought out this, which is almost like a quarter century old study, JET study 2003 published. But look at, wait a minute. This is a bipolar 1 natural course, which I studied for about 25 years. I think all of you know this particular paper and then the slide. Asymptomatic is 53%. Here, this SSD, this MDD is, let's see that 9%. Subsyndromal depression, minimal depression, all these things are taken care. It's not that we ignore the subsyndromal symptoms. It's not that we ignore the minor symptoms. Once all these are considered, still 50%, 3% of the time, that's what Dr. Himakar was talking about. In the life of a bipolar patient, almost 50% of the duration, he's totally asymptomatic, which I think we should not forget, which is going to be very, very important. Come to it a bit later. Now, this is year 2000. That is the period when International Society of Bipolar Disorders was formed and the Bipolar Disorders Journal was coming up. This is Baldessarini's plea saying that, please, this is one specific illness. Don't weaken it. Don't trivialize it. There's a classical bipolar disorder. It gives us the hope of having a very homogeneous group, but if it would be tragic to weaken this disorder, that's what is happening now. Bipolar 2, 3, 4, 5 spectrum disorders and all things. This is the plea which has come about quarter century before. Yes, I think this was the topic last time I talked about. Once again, with more confidence, I go into this. This way I said that I think all of you have gone through this. Some of you may not like it. Diagnosis is very important. We are medical practitioners. Diagnosis indicates prognosis, directs therapeutics. Sir, I just wanted to your attention here. One episode of mania is enough to make a diagnosis of bipolar disorder. I think all of you know I don't have to talk about it. You don't need depression. Then to diagnose bipolar 2, you need one episode of hypomania plus one episode of major depressive disorder. Next sentence, I want all of your focus on that. Suppose it's an exaggerated statement. Suppose there are 1,000 episodes of hypomania, but no recorded episode of major depressive disorder. It will not be bipolar 2, sir. A lot of times you don't understand that. A lot of times we don't understand that. No, this is what it is. BD1, mania is the pathognomonic thing. BD2, hypomania, but there has to be MDD. Why? The confidence, diagnostic confidence in hypomania is weak from day one. That is the reason. Just there are 1,000 and million episodes of hypomania. Bipolar 2 disorder cannot be made if you don't demonstrate and record major depressive disorder. For all the youngsters, I think you should remember. This is a misconceptualized diagnostic entity. So what? What's the problem? Therapeutic consequences are huge, huge, not a small thing. I don't think I have time to talk about all those things today. But the most important thing is suicidal risk. Maybe later, if there's time, I can show you one of the case reports which has been published. Suicidal risk is this. This I've been talking about exactly 11 years. 2014, I said bury bipolar disorder 2. The recent article by none other than Jin Mali, who was the president of ISBD, Canadian Journal of Psychiatry, 2019. This is exactly the words which I have taken from the journal. All of you can read that. It has run its course, served its purpose. Illogical definition of hypomania. Non-clinical elevation of phenomenologically accurate. It's not appropriate to pathologize. This is one of the biggest things I keep talking about. Borderline personality, a lot of times gets mistaken, overdiagnosed as bipolar disorder. It's important for classification systems to examine the evidence and revise diagnosis. And ultimately, in this paper, they conclude we propose the abandonment of bipolar 2 as a diagnostic entity. I think this is one of the greatest things they have done, one of the biggest beneficial thing and then positive thing they have done in the last decade in the concept of bipolar disorder. As a consequence of this, Jin Mali is from Australia, and the Royal College of Australian is on kind of guidelines, 2022, there is no diagnostic entity as bipolar 2. Yes, remove that. So imagine a patient with borderline personality disorder being diagnosed as BD2 and put on so-called prophylaxis and mood stabilizers rest of his life. That's why I said that the damage is huge. I generally compare this with simple schizophrenia diagnosis, which was sometime back in schizophrenia, but this does more damage than what is the diagnosis simple schizophrenia we made that time. This is what bipolar 2 is. Sir, have a look at this. Asymptomatic 44%, depression is 52%. What is hypomania? 1%. 1% is hypomania. Still, some of you may argue that in 1% is there, doc. Even that 1% is very, very fluid, very, very fluid. So once you make a diagnosis of bipolar disorder, generally you say that as on today, I think that's what recently some of you attended ANSIPS, the Lashmi Atham's presentation, the concluding remarks, I was extremely happy that he said that antidepressants can be given, let's give that. But till now, no antidepressants in bipolar disorder. Generally, that is what the academicians say that. This, I wanted to read every single line. This is the paper in 2021, Goldberg's. How much is the debate over antidepressant efficacy, safety is an artifact of study methodologies. Every postgraduate today knows that the moment you diagnose bipolar disorder, don't give antidepressants. Number one, they are not effective. Number two, they produce switch, rapid cycling. This is a teaching we tell them this is what is being. What exactly says that it's an artifact? Let's read the sentences. 70s, 18s, there may be some antidepressants which, as in the switch, which was supposed to be an hypothesis, has become a dogma. And the relationship which was supposed to be incidental, it has been dogmatized as a causal relationship. And then we shy away from antidepressants. So what? What's the problem? This is the problem, sir. Veritable cessation of randomized trials for bipolar. The entire, the pharmaceuticals have stopped doing any trials on bipolar depression for the last quarter century. This is the most important thing. Self-imposed moratorium on placebo-controlled trials in bipolar depression. Now, sir, can all of you understand? In the last decade or two, I think I asked this question also. Surprisingly, started with quetiapine. Quetiapine is anti-schizophrenic, anti-manic, and also bipolar depression is anti-bipolar depression. Then came lurasidone. Lurasidone is anti-schizophrenic, then manic, and then antidepressant. Then came cariprazine. It first is an anti-schizophrenic and then comes as an antidepressant. Now latest we have is lumateperone. We started with schizophrenia and then. This is because the entire pharmaceutical industry stopped doing any kind of studies on bipolar depression to try to find out the molecule saying that antidepressants are not effective. Look at the huge impact of one, which is a hypothesis which has got dogmatized and then extended, extrapolated, exaggerated reaction of this particular thing. This is what they affect. And today we are left with the controversy regarding antidepressant bipolar disorder is huge. There's always a discussion, nothing else happens. Now, I'll end there and then come to, this is one of my favorite bashing drug, maybe to tell you, in the last more or less half a decade, virtually I stopped. Almost, I think about 2017, we have written editorial and IJPM. I was the editor that time. But for lithium, no other so-called mood stabilizers do not seem to be stabilizing modes. When I read this, the latest, last January, this is a categorical statement issued by UK authorities from today, 31st January. Significant risk of serious harm. Valproate must not be started in new patients unless two specialists. They're very clear. Almost about 5-6 years back, European Vigilance Commission has given a saying that valproate in childbearing age women, now extended to men also, there is not sufficient evidence for bipolar disorder. It's only in epilepsy it has to be considered, otherwise no. See, this 30 to 40% of children where mothers have taken it, they have learning disabilities. So it's a categorical statement. 31st January 2024, UK government, UK European Vigilance Commission, and then there's European Medication Agency says that you cannot prescribe valproate. This WHO told that 2023, but unfortunately, fortunately, whatever it is now, here I say that valproate is not FDA-approved drug for so-called mood stabilization or prophylaxis. The most rampant prescription in bipolar disorder I see is that valproate. In me, personal opinion, sir. Personal opinion, some of you may agree, may not agree. It doesn't work, sir. There's nothing. Next, I go straight away to lithium. Lithium was First came into market in 50, John Cade, and 75 it has got approval from FDA approval. But surprisingly, in the last few years, lithium prescriptions are going down. This is what actually I thought of discussing in detail, but right now I'll leave it like that, maybe in discussion phase. If you look at this in the last 25 years, this is the data is from 1997 to 2016. This is lithium. Lithium prescriptions are decreasing. Mood stabilizers, any mood stabilizer is decreasing. This is a clinical practice, sir. This is where the biggest discrepancy. What I say is that all the academics, they say that lithium is a gold standard, prescribe lithium. The clinicians are just not bothered about what academicians say that, and they are not prescribing lithium. They are not prescribing mood stabilizer. What is the reason? It cannot go on in the discard. Either they sit down and listen to experience-directed evidence and start looking at lithium fresh from people like Dr. Himakar and then some of the senior practitioners who have data for the last 30, 40 years and relook at it. Or we sit back and learn that why we are not writing lithium as clinical practitioners. Something has to be done. It cannot go like that. Now, like a journal paper start writing about lithium, you prescribe, and then another practitioner says, giving lithium. Why? What is the reason? Umpteen reasons, but this is the reality. Now, I think Dr. Simakar made a mention about two drugs and then polypharmacy. This is the one slide I just wanted to condense this in this. Robert Post, 2010. Robert Post is the man who proposed this theory of kindling hypothesis in bipolar, and that is where we started prescribing anticonvulsants in bipolar disorder, starting with carbamazepine. He is the main proponent of it. He published a paper in 2010 where he says that average number of drugs used 7.3. Every time I read this paper, I get into that. This paper, the authors are all the big names in bipolar disorder, all past presidents of my ISBD. Then polypharmacy is being, very openly is being supported, saying that you need this many drugs. And then I was looking to the literature, 2007, there's a paper, functional outcome in BD, they wanted to look what are the factors. High functioning do not differ from those with low functioning with respect to clinical factors, but one surprising, unexpected finding is that more the number of drugs, more functional impairment. For a long time, I had only this paper. I was looking at it. It's a 15, 17-year-old paper. I can't keep quoting about 2 decades old paper. Then I looked at this paper. There's another paper which has come in 2022. This is a huge paper. It's from 13 cohorts from 7 countries, global bipolar cohort. It published in 2023. Lower functioning was associated with greater total number of psychotropic medications. Here, this is the question I want you to remember. What are we trying to do in trying to so-called stabilize mood, use 7 drugs as advocated, and let me put it maybe categorically, my opinion, a bipolar disorder patient who is otherwise a good prognosis patient who nicely gets into a symptomatic recovery, because we are pushing so many drugs, we are not allowing him to get to the functional recovery. Iatrogenic reasons, symptomatic recovery, functional recovery. One of the reasons is polypharmacy. One study in 2007, one study in 2023 have clearly shown, at least cut down. If you look at CTP, 50% of the patients are now 3 to 5 drugs. That's what now one of the latest CTP says that. So this we have to be careful when we talk about rational polypharmacy. Some people don't like it when I say that it's not rational polypharmacy, it's a desperate polypharmacy. For me, it's always a desperate polypharmacy. But not like people are angry with me when I said that, right? I can't help it. Now, I'm coming to this. Neuroprogression. Oh, this is what has been talked. We all listened to this for a decade or more than that. This is a nice paper. Some of you may say that last time somebody told also, MSLD, you seem to pick on some papers which are projecting something. I think almost all my papers are some of the recent works. I am not quoting 20 years or 30 years back papers, and most of these are from Journal of Bipolar Disorder, which is the official journal of International Society of Bipolar Disorder. This is a huge statement. 23, he says that neuroprogression hypothesis. No, there's no evidence. It's time to apologize to all the patients. And then long-term course of cognitive function, we all accept very casually, we accept cognitive function deteriorates over a period of time. This study has shown that over a period of 10 years, there is no difference between healthy controls and patients with bipolar disorders when it comes to cognitive functioning. If there is one reason why there is a deterioration, that's because of polypharmacy. So in our over-enthusiasm to prevent the episodes and so-called mood stabilization, we are over-drugging the patient and and in the process, they are not having the so-called functional recovery, which I look at it as a quaternary prevention is very important. This is an important paper. Shifting from prevention of the next episode to optimizing inter-episode functioning. Till now, this is what I talk about, paradigm shift. Till now, bipolar disorder means, right, no short-term, long-term, prophylaxis, mood stabilization. I think they said that at what point of time is there enough evidence to shift paradigm? I think Stezilevich and colleagues argue that this is the time there should be a paradigm shift in the management of bipolar disorder. It's important to control the episode. It's important to look at prophylaxis, but also you look at what is inter-episode function. And then time has come to question the infinite maintenance treatment of bipolar disorder. For some of the postgraduates, this may look a little bit off kind of thing. What is this man talking about? We are all taught more stabilization, but now the time has come to question some of the concepts. That's why I said that is it time to relearn? This is just maybe the last slide, sir. Why I'm continuously keep on talking about all these things, paradigm shift and then time to relearn. I want all of you to focus on this particular patient. This is a surgeon, 54-year-old laparoscopic surgeon. He came from Madhya Pradesh. I saw him first in 2018. Before he came to me, he supposedly had an episode in 2003. I have not seen. I have multiple cases, some umpteen cases are like this. This one, because he's a doctor and a surgeon, I just wanted to present to you. First episode was supposed to be in 2003. He was admitted in a premier psychiatric institute, started on lithium. So since 2003, supposedly mania, I have not seen. Diagnosed as bipolar, from 2003, he is taking lithium continuously. This is 2025. 22 years he has been taking lithium. All of you know, with increasing uses of lithium over a period of time, the risk of renal disease keeps increasing. No further episodes of mania afterwards. Regular practice as a surgeon is doing very well. He came to me in 2018. He was on 600 milligrams and quetiapine this. He came to me because he has some relatives in Hyderabad. So the other doctor who was treating said that you go to Hyderabad, anyway you're going, visiting frequently, so go and see MS Reddy because he takes care of it. That is why he came to me. When he came to me in 18, BD, currently euthymia, alcohol harmful use, he is diabetic. Then I said, you continue, because he's come from a very big institute and his patient is doing well for the last 15 years. And then he came again in 2023. I even asked him, why did you come here again? He didn't come to see me. He came to some other hospital for some other purpose. And then he said that anyway, I'm going there. Let me also visit my psychiatrist, his wife and brother-in-law. No manic or depressive episodes in 2003. And then the last visit when I saw him on 24 March video consultation, this is the lithium, this is what euthymia. So, sir, in front of you, there's a surgeon who is an excellent surgeon, laparoscopic surgeon, who had a first episode of mania in 2003, supposedly. I have not seen him. And after 2003, he neither had a manic or depressive episode till 2024, the last I saw him. What should I tell him when he asks? Does he say that he is one of the patients where lithium cured him of bipolar disorder? Or Dr. S. Himakar told that this is a patient, one of the rare patients who had 1 or 2 episodes of bipolar disorder and the natural course of it, he didn't have an episode. What difference does it make? Why, it's going to make a huge difference, sir. He is going to depend on you. You are the expert doctor. You say that continue lithium, he'll continue. He continued. He believed me and the other doctor continued. Suppose I say stop it, he's going to, maybe he'll stop it. Do you take a decision asking him to stop because 22 years he didn't have a manic episode or depressive episode, and at least to save him from getting into CKD? or keep a blind eye and say that lithium is a gold standard, lithium is very useful, maybe this patient is going to continue. What should be my advice? The dilemma is the scare. If I reduce it and stop it, in case if I have it, oh my God, what did I do? My God, this is a teaching. I am the culprit. I did precipitate. If I don't, am I doing the right thing? Now we understand that this is one particular case. There are hundreds of cases like this which come to us.
Yes.
Do we continue to stop it? This is what it goes on. Maybe I'll be very happy if you advise me whether to continue lithium or not. And yeah, this is on the lighter side. Right. Why MS said you talking so much about it? You seem to be so worried about bipolar patient. Yeah, I seem to be worried. But if you say that, if you don't think of your past patient, don't think of your future patient, just think of your present patient. When you're not there, hospital was functioning. When I'm going tomorrow, also the patient will continue to have. Somebody else will see, a lot of youngsters will see that even after you leave, it will function. Patient who is yours today or somebody else's yesterday, this is what the Bhagavad Gita for the doctor. So because you're worried too much, this is responsible for your grief. And that's why this kind of talks about relearning about bipolar disorder. With this brief, I think maybe we have another 10-15 minutes. Please feel free to ask questions. Anything you can. Opinions, please comment. Anything. Thank you very much. Thank you, sir, for very patient hearing. I'll stop my presentation. Thank you, sir.
Sir,
It's
an excellent presentation, sir. Today, I consider that it is my good fortune to participate in today's program as chairperson. You have definitely raised very interesting, very relevant points. Like as you say, like discussing about the doctor, no, last patient, like that, many cases we come across. Like sometimes I tell my experience when a patient is visiting us repeatedly or last 10 years, 15 years, what I think is that lithium is helping him, or naturally the illness has relieved and he's cured of that illness. What should I do now? Like that, like in that situations, sometimes I reduce the lithium dose a little bit, and another 2-3 months he comes and tells me that sir, some sleep disturbance has come, some the symptoms they used to highlight. That then again I'll be careful, and again I'll come back to this thing and come to continue the dose. And one good fortune is that they are maintaining very low doses only. Like for example, 600 milligram of lithium or 900 like that one, but they never more than 900 milligram doses. Sometimes 450 lithium is also sufficient for them. So that is a great dilemma. Like in that situation, what I should think is we should negotiate with the patient. Like, see, for so many years, you are symptom free. And if the patient asks also, I will not take the initiative mostly. If the patient asks, sir, how long I should continue, then I'll tell him, like, there is a chance of getting an episode if you stop the medicine. But so far, you have not got it last 10 years. Now you think the time is ripe enough and I can afford an episode right now, then you can stop on your own. Then what he says, doctor, if you say to stop only, I will stop. Otherwise, I will not stop. Then what I'll say is, wow, let us continue it. That's what that stand I'll take. So this is how the things we will manage. But really, it is very definite kind of thing. Very frequently, we come across this kind of situation. Definitely, it's a dilemma to us. But I think this kind of safe stand I take, and I continue this thing. So now I declare the topic is open for discussion. I invite all the participants to seek your clarification, whatever from Dr. Ms. Reddy garu.
Yeah, there's something in the chat box. So there is something by one Dr. Chandresh. Now, like when I said that at the end of a couple of months, when you look at the primary outcome, if you delay it, the risperidone, valproate, and the lithium placebo, everything becomes equal. Just to impress that the natural course of illness, that's why a lot of times we can get mistaken results even in RCTs also.
Oh.
So if it is first episode, maybe I think after 3-4 months you can afford to stop the antipsychotic drug and then wait and see. Unless it's a many episode when you know the
Absolutely.
course of it reasonably, I think we can give it a try. My
Yeah.
presentation is already put it on the WhatsApp now, except 1 or 2 slides. Most of the slides are there with you. First episode, how long should we continue lithium? Sir, these are the kind of $1 million questions. And if you want me to share my opinion, of late, the first episode mania, I will not give lithium. I know seniors won't like it.
Absolutely.
I will not give lithium. Because why should I put him on lithium? Because lithium, see, like today's presentation, I didn't talk much. I think maybe 13th we are going to have a presentation at Hyderabad where I'm going to use a little bit longer time. In my brief talk, I said that for 10 years I didn't have the courage to talk about lithium, but this time I pulled up all my courage to talk about lithium also. Because lithium, how many of us use lithium as a standalone drug for management of mania? Nobody. Nobody. Then why do you talk about it like that, sir? That's where. So I don't start, sir. The Berlin antipsychotic, usually maybe it's about 4-5 months or 5-6 months time. I try to reduce. Here, let me tell you, majority of the patients do well, but they did have some hard knocks when there's an exacerbation of symptoms. It's like most of the patients do well. That's the only thing I can say. No doubts are naive. When I read about very naive doubt, I will know that it's going to be the most difficult question to answer. Different guidelines give different algorithms for continuation as well as selection of drug. The evidence presented by you is also quite revolutionary as we step into psychiatric careers. Right. See, I don't have a choice today. Sarath has taken the call. The next, actually, 13th presentation, I initially decided that I don't want postgraduates. I'm scared to talk to postgraduates sometimes because I don't want to give them a totally different picture. I don't want to confuse them. I'm accused of 2-3 times that I said you confuse postgraduates. My only answer is all postgraduates in psychiatry are very smart and intelligent people. They will not get fooled by somebody like me, somebody like this. It's only giving them a different perspective. There's a perspective I am giving. I think for the question what you asked, one of my standard things in the rounds is that if a DPM first year student who has just joined in my, like an Asha hospital after 1 month, if that girl comes and asks me, quetiapine, I learn only about quetiapine. If it is schizophrenia, I'll give quetiapine. If it is mania, I'll give quetiapine. If it is bipolar depression, I'll give quetiapine. Mood stabilization, I'll give quetiapine. Is there anything wrong in that? I don't have an answer because CanMat 2018 says that you give that. So that is the dilemma. I think very valid question you asked. Maximum dose of lithium, it's more than the dose. I think it's the blood levels. 1.2. Beyond that, you feel uncomfortable. You don't go beyond that. Usually between 0.78 to 0.9, that's it. Even one little bit of try to reduce unless it's an acute episode where you want to give a higher dose. That's it. It's usually about 900. 1200 is the maximum. I have never gone beyond 1200. That's also very rare. Anybody, if the chairperson permits, if somebody wants to come live also.
Yeah. Sir, your presentation is as usual, very good.
Namandra, good
Yes,
evening.
sir. But in day-to-day practice, and also the literature, now there's so many concepts are coming up, like staging of bipolar disorders. So many papers are coming up, like what they do for cancer patients. And we have got a lot of literature also, like, for genetic markers and then imagological studies. And this is a very highly heterogeneous group of disorders. So whatever you are talking is definitely patient friendly, and the maybe empathetic point of view is right, but it's not true for most of the patients with long course bipolar disorders. There is lots of rapid cycles, and then with psychotic features and repeated admissions and all that, that we see very frequently. And especially with the diminution in the application of ECTs in the peripheral practice, we don't have any other option other than using these mood stabilizers. And what the physicians do, like for hypertension, diabetes mellitus, if you really try to see from a neuroscience perspective, I think we need to continue these medications. What is wrong as long as you are monitoring them? Because you are monitoring for their regular lithium levels and then like lipid profiles and then their comorbidities. What is wrong in continuing this medication as long as you monitor them?
Sir, there are I think as a senior practitioner who have been practicing for such a long time, I think you have raised a very, very valid questions. I know that this can be a little bit on the other side of it. All the points, what you say, I take it. What is wrong in continuing medication if it is useful? But is it useful, sir? No. Let me make it very categorical statement. This way I said that about 7-8 years back, I wrote an editorial, but for lithium, no other mood stabilizer seemed to be doing the job of stabilizing the mood. I feel like I maybe valproate, lamotrigine, and then none of these, it's a natural course of the illness where some of these things take advantage. And can you say that a 2-year study, can they talk about prophylaxis in bipolar disorder, sir? Natural number of episodes in 10 years is about 4. So you do a 2-year study and say that this particular drug has got a prophylactic effect. No, sir, it will not be taken. So my point is, if lithium is not doing the job of preventing the next episodes, delaying the next episodes, reducing the severity of the next episodes, just for the sake of fact, somebody told it in CANMAT guidelines, I don't want to continue. There are umpteen patients like that. Then other points, sir, I don't think we can. Of late, I've been talking about rampant overdiagnosis of bipolar disorder, borderline personalities, OCPDs. The culprit is, I think Dr. Himakar very clearly told, we were seeing the nice group of grandiose patients. Now we see more of irritability. The entire damage in DSM has done by this including irritability. Intention was good. Irritability including that. One of the common things I say is borderline personalities, they have depressions, they have suicidal risk, they are irritable. Diagnosed as bipolar and come into this. We just don't know. See, if the drug is valid, if the drug is useful, please, sir, we all have to. We all have to. But the thing is that when it is not, I don't know. That's why I have so many cases where actually, can you please mute Mark Kovanoor, if you don't mind? Yeah.
Sir, thank you very much.
It is something.
Yeah, thank you very much. Right. Thank you, sir.
That's what, sir. Lumateperone, I don't know, it still started only on that, beyond that now. With mixed obsession, differential persecution shall be considered. Yes, sir. This is where, this actually somewhere I said that. That's why I put that Baldessari's paper saying that, let us wait. There are papers. See, we talk about duration of untreated illness in schizophrenia. But we don't talk about duration of untreated illness in bipolar because the concept is not valid. I think Dr. Raman Rao very beautifully talked about staging. This is again another concept. We say that there is no staging in bipolar. There's grouping. Grouping has to come. So there are papers saying that suppose you delay the treatment, no, it's not going to affect the entire course of illness so much. Unlike in schizophrenia, we can wait. Take the depression. The day when he develops mania, clear cut, please go ahead all out to treat the bipolar. But don't get obsessed with preventing the next episode unless you see, as he told, that rapid cycling or every year episodes. Then we can't help. There are some patients, we are all stuck. There's no choice. But polypharmacy cannot be from day one. If any of you treat an acute manic excitement with lithium, sir, please let me know. only with lithium. And suppose you said, why should I give only with lithium? Why will you risperidone plus lithium? I'll say give only risperidone, sir. It's only thing. That's way. Lifelong maintenance treatment. A lot of our patients are on maintenance treatment similar to whom you mentioned. We have to, here, what I say is that I cannot make yes or no. I have to take a call. This is a surgeon. 22 years, he never had an episode. But I still don't have the courage to stop it but I'm increasing the risk of CKD for him. Tomorrow he develops, his creatinine goes into 3. Can I completely wash off my hands and that I am not responsible? If he was having 10 episodes in between, right, I'm justified. If he didn't have an episode, okay, he's coming, he's doing good, refill. Sir, may not be, sir. We have to take a call. I think we take a call on every individual patient here. But the only reason why I said that, as on today, in spite of talking all this, I didn't have the courage to tell him because it's been so much ingrained in me.
Yes.
That, stopping lithium, stop. I want you to think about it second time. That's the only idea, nothing else.
So Dr. Ramesh Babu, sir raised
Good evening, sir. Good evening, sir.
Yes, good evening. Good evening.
Very nice presentation. Thanks a lot, sir. Just I have one doubt. In my practice, I'll be getting some patients who are getting a manic episode once in 4 to 5 years. And in between, they'll be totally all right. They are totally all right. Do they require long-term prophylaxis?
Sir, if it is my patient, I will not do, sir. I'll treat mania. At the end of 6 months, I'll stop all the drugs. If he's not going to have, if he's not riders, if he's not going to have, how can you be sure? I don't know. Because only senior practitioners know this. A lot of youngsters may not even understand what I'm talking about. Senior practitioners know. If I'm very definite, it's once in 4 years. Clearly, 3.5 years, I'll keep him off drugs. At this point, I think what Dr. Raman Rao told is right. If we have a drug which can prevent his next episode at the end of 4 years, I'm with you. I'm with you. But as on today, there is nothing. Even lithium, I have doubts, sir. There can be some patients, not many patients. I think we all studied, sir. Lithium works only in 60% of patients. And then the compliance is less than 50%. And then the dose maintenance is, as Dr. Himakar told, most of them come with 300 milligrams, 400 milligrams, sub-therapeutic doses. How can we attribute that to lithium?
To the benefit, yeah.
Difficult.
So we have to treat the episode and prophylaxis is not necessary for them. Prophylaxis.
Correct.
Yes, sir. You are forcing me to repeat it again.
Ramesh Babu, I want to say something.
Okay, sir.
Sir, can we definitely say that frequency of once in 4 years or once in 5 years, once in 3 years, we cannot say that.
Okay.
This time the episode can come next year also. We do not know. So that kind of thing, prognosis, prophylactic lithium is better to maintain. Yeah, definitely better to maintain.
Okay.
Sir,
See that.
Thank you,
See, Dr. Chairperson's comment is that. But there's the point is that this is what our teaching was all along. All along, that was our teaching, which we have been doing it. But can we look at it? That's where that paper has come. Is it time to rethink that the long-term maintenance of treatment is a must for every patient? I think we need to have a rethink.
Yes.
Only point here is that, sir, I am not stopping the drug. Patients are stopping the drugs.
yeah. So many times it happens. Like patients belong to low socioeconomic status. So say they may be a rickshaw puller or laborer or something like that. They stop medicines, do well for sufficient time, and again when you get episode symptoms, you come back to us. Those things also happen, no? So
briefly,
it all depends. We have to negotiate.
Yeah,
we have to negotiate with the patient, see weigh the merits and this thing, then decide. Prophylactic treatment.
If some of the seniors can suggest what I could have done with the doctor. Some of the seniors, but it's open. I do mistakes. Do you want me to, if it is your patient, would you continue lithium or would you give him a chance to stop, sir? Any of you, sir, feel free.
Sir, I'll continue, sir. I'll continue. I'll discuss with the individual because he is also a doctor and he knows. I tell by giving this kind of low dose medicine, which is helping you, or sometimes other thing also may not be helping also. We do not know why they didn't have mania. May not be helping, but as the knowledge says, prophylactic will help you in your professional life. We cannot risk of having another manic episode for you. So it's better to continue. Like that, we'll continue. And actually, if we negotiate and if he says that, sir, I can take a risk, I can see, I want to see myself, I don't want to trouble my medicine, my body with the medicines and all. I want to stop and see, then I say, okay. Because there's sufficient reason in this thing. But you ask me a choice, I'll not say, don't have an episode again.
And at this point, sir, before I think Lokesh Reddy responds, one of my regular, and what I see is that patient wants to stop. Relative says that, no, don't stop.
Sir,
it's the relatives who are putting the pressure. No, don't stop, doctor, don't stop.
It must be a collective decision. Those relatives also should be respected and they have to be discussed. Unless they are concerned about the patient, why they say not to stop, sir? Patient.
It's like this, sir. My understanding is relatives want the patients never to be in manic. It's mildly depressed, it's okay. For the patient, oh God, I don't want to be in depression. I would like to be in other ways. That's a constant kind of a thing which happens. Yeah, Lokesh, I think you want to say something.
Sir, my question is about...
Can I say one question, sir? One question. My experience is, I think we have to explain the patient family members, the side effects also. If the patient takes long term, these medicines for long term, they may get some side effects also. So we have to explain the advantage and disadvantage of continuing the medicine for a long time. Because one of my patients long ago, he was meditating for many years. Then I stopped tapered and stopped medications. Then he has relapsed and he did not recover even for ECT and all other medications.
Very difficult.
I'm very guilty. Even now, I'm feeling guilty.
Yeah, definitely.
I agree with you, sir. I empathize with you. But the thing is, in that situation, what I tell them is, why you are worried about side effects? The main effect is also is preventing it. To side effects, we are monitoring you. Regularly, you are coming to us. We are seeing you. If it comes, we will warn you. To prevent those side effects only, this consultation is required. Otherwise, I can give you a packet of medicine that use this medicine for 3-4 years and come to me. No need to come to me every 3 months or 4 months. So I tell them like this. See, we see me every 3-4 months. We'll try to monitor the thing. We see that you are not having any side effects. Then we'll continue the medicine. That's how I explained that.
Yes. Thank you.
Sir, my question is about bipolar depression. Actually, treating psychiatrists, we feel that it is easy to treat manic episode rather than a depressive episode. Sometimes it will be so frustrating that we expect or we pray if the patient shifts from depression to mania, it will be better so that we can treat it very easily. And as I've seen, if you see the research, usage of antidepressants is totally not happening. So in your clinical practice, do you use antidepressants, at least in the cover of a mood stabilizer?
Yes,
if so, how effective it is?
Yes, we use. They are going to benefit. We don't hesitate to use antidepressant. But as you say, the mood stabilizer cover is always necessary, so that you have taken necessary due precaution to prevent a manic. Definitely, sir, you use antidepressant, no issue. I think Dr. MS Reddy will enlighten us.
Sir, I use, with your permission, I'll just go back to my presentation and then just maybe 2-3 points, which I would like to. Maybe I think these are all senior people here. I just want to show. This case, sir. This is a case which is published in the Bipolar Disorder Journal. It's a recent 2000. When is this, sir?
24.
24, right? Recent. This is the case where it's been published. You see, this diagnosing bipolar 2. Look at the number of episodes. Depression. This is a suicidal risk. After that, hospitalized. Again, depression. And then first childbirth, second childbirth. I used to draw this. Luckily for me, they have this diagram in the journal itself. These are two. If you look at the manic episodes, sir, here, it's not going beyond the mild. Right? It's a mild. So, sir, here, this is to be my regular question. I treated him with escitalopram, he improved. Escitalopram, sertraline, escitalopram, paraxin, whatever it is, I improved. And here, what do I give him? I think that's an excellent question by Lokesh Reddy. When it comes to here, they tell me don't give escitalopram, don't give sertraline, don't give this thing now. Give quetiapine. That strikes me. That bothers me. And that is where already a patient who had a significant suicidal attempt, quetiapine, does anybody know what is the anti-suicidal effect of quetiapine? We don't know about luracidones and cariprazines and then lamatoprons. When patient has improved with escitalopram this many episodes, why he doesn't improve with this? How does the logic, where does the logic? This paper, when they published recently, 24, this is the comment of the author. I think you can go through, sir. It's an OCPD. I don't know how he came to that conclusion. Patient was treated with sertraline. Quetiapine has been found effective in various psychiatric disorders, including bipolar 2 and OCD. Who told that quetiapine is effective in OCD, sir? Does anybody here agree with quetiapine being effective in OCD?
No.
And how can this has come to the journals, and the doses he uses 125, and he mentions that dysfunctional anger, it has to be diagnosed, this antidepressant should be avoided. I think exactly what Dr. Lokesh Reddy was asking.
Yeah.
And he says that because he had these two so-called mild episodes, don't give sertraline, give quetiapine. This is what I think Dr. Lokesh Reddy says, it's where we are all struggling.
Yeah.
That is why this, whatever I talk about, that's why I said that bipolar 2 diagnosis is doing much more harm than what it is supposed to be helping. It doesn't. If you go by the guidelines and then you cannot start antidepressant here. That's a frustration. I think every day I see the frustration, whatever Dr. Lokesh Reddy told. And if you ask me, I give antidepressants, sir.
Sir, lithium will consider
lithium as an antidepressant, sir?
Antidepressant is in this case also because already
there is another slide which I am sharing with you.
Sir.
I'm sorry. Right. I just kept some of these slides, but now I didn't want to go through this. Yes, sir, this slide.
Lithium
because he has a suicide attempt also.
Yes.
Lithium we can try, I think.
Can give it a try, but how effective it is. Here, this man has told, he shared our, whatever feelings we have. So there's a lot of literature coming up. I think what I say is that some of the points what we raise, I know that there's a lot of things which we learned and then practicing for so many years. Maybe once in a while we may have to look at it from a different perspective. Doesn't harm us. Look at it and then we'll see. That's the only thing. That's it. That's where I wanted to show the slide. That's it.
I think we have a wonderful discussion, sharing good knowledge and experience. I once again consider myself as fortunate to be participating in today's program as chairperson. Thank you, MS Reddy garu.
Thank you, sir.
Now I'll hand over to the organizers.
Now I request Dr. Uma Jyoti Madam, co-chair of CME committee, to propose the vote of thanks.
I thank Dr. M.S. Reddy Garu for enlightening us with his vast experience in treating bipolar disorder patients, sir. The studies you presented regarding polypharmacy are very eye-opening, and I think all new PGs will learn a lot from this webinar. Thank you very much, sir, M.S. Reddy, sir. I thank Dr. GVS Murthy Garu for presidential remarks and Dr. Lokesh Reddy Garu for welcoming the participants. And thank you, Dr. Suresh, for introducing chairperson. I sincerely thank Dr. Himakar, sir, for accepting our invitation and as chairperson and actively participating in the discussion and clarifying a lot of doubts. Thanks to all office bearers, particularly Dr. Sarath for his dedicated work, and thanks to all participants for participating and asking questions, for their enthusiastic participation. All PGs, I think they learned a lot. And thanks to Team Jonalta for their technical help. Thank you very much, all of you.
Thank you, ma'am.
Thank you, sir.
Thank you. Thanks, everyone. Thank you so much. Thanks.
Thank you, sir.
Thanks a lot. It's program which I love
Thank
and
you,
then
sir.
I enjoy. Once again, thank the
Thank
entire
you.
AP chapter,
Thank you
all of
very
you.
much.
Thank you. Thank you, sir. Good night.
Right.
Good night.
Thank you. Good night, sir.
Good night.